good afternoon and welcome to the presentation today. It's got quite a long title, but you can see that it's about falls, root cause, and then implementing successful interventions to prevent falls from occurring. My name is Toni Kettner, and I'm joined by my colleague, Kim Heft. We are both quality improvement advisors for Superior Health Quality Alliance, and we're so thrilled that you can be here today. Lots of great information that Dr. Walsh is going to share with us. So before we turn it over to Dr. Walsh, I just wanted to talk about or remind you of a few housekeeping details. So we are hoping to end the presentation at about 50-minute mark. So there'll be plenty of opportunity to ask questions or to make comments. We would encourage you as you're going through the presentation, if you think of comments or if you have comments or you have questions, please put those into the chat. And then Kim and I will monitor that and we'll kind of accumulate those for Dr. Walsh at the end of the presentation. We'll also remind you again at the end of the presentation, if you prefer to ask a live question, how to do that. So let's see, I want to welcome our speaker today, Dr. Kathleen Walsh. And Dr. Walsh, I'll turn it over to you for your introduction.
Oh, I really appreciate the opportunity to speak to everyone today. And this is an issue that's near and dear to my heart. I am a associate professor here at the University of Wisconsin in Madison, and currently work for the last 10 years. We've established a clinic called the Faint and Fall Clinic. So I'm looking at patients who could possibly be fainting and falling, or those who are just falling. My background is in internal medicine, emergency medicine, geriatrics, and cardiology. So a combination of things that we look at here. So let's get started. So when you see a patient here, and this is something commonly I saw when I was rotating through or taking care of patients both in the nursing home, assisted living, and then when they come in to see me in the clinic or the hospital, you'll see this fall risk band. And the key is we see it, and sometimes we just, okay, they're a fall risk, but take a minute and ask yourself, why? Why are they a fall risk? And this is what we're going to get through today. And I hope by the end of this talk that you'll be able to identify not just one, it's usually more than one issue that's causing someone to fall, but multiple issues and how to take care of it. So the objectives today include recognizing common causes of falls in our older population, determining the appropriate diagnostic assessment of people who do fall, and integrate targeted interventions and treatment strategies to reduce fall risk. So we do have a little bit of an outline. We'll talk about the facts, who's at risk, multifactorial assessment, interventions, and really, I get to the bottom line. And I say that a lot to my residents and the other faculty I'm working with. What's the bottom line here? So just a few facts. If you look through that, CDC has a plethora of facts when it comes to falls, and they've put together a nice steady fall risk intervention that we can use, and I'll talk about at the end as well, as long as the National Council on Aging. So next, about every 11 seconds, and I worked in emergency medicine for a long time in level 1 traumas, and we would see so many of our folks coming in over the age of 65 with a traumatic injury. And if they're on a blood thinner, well, it triggers the trauma team, and it's a big deal. Next. So we look at the fall death rates in the United States, and this has increased from 2007 to 2016. So how many people actually die from the fall directly related to that fall? And it is increasing every year. Next. How expensive is this? Very expensive. Not only with Medicare, but private out-of-pay and Medicaid. So over $50 billion a year. And this is documented in 2018. So it's probably about $70 billion at this point. About how common do people over the age of 65 fall? About 1 in 4 folks over the age of 65 fall each year. And this could be your relative, your parent, you, your neighbor, and people that you work with. People do fall. They're not always seeking medical care, but they do fall. Next. So yes, the aging population in the United States. In certain areas of the United States, they're aging a little bit quicker than others. So the darker the color, the more people over the age of 65 And if we go to the next slide, Wisconsin, Minnesota, and are listed there. So in particular, Wisconsin, because I focus a lot on when I give talks throughout Wisconsin, the aging population. This is 2015, the darker the color, the more people over the age of 65. But if we go to 2030, next slide, it increases. So you look at the older population in northern Wisconsin. You can do this as well for Minnesota and Michigan. You can look at every county and they will have the average age of your patients or the population in that county. So what about falls? This will go to the next slide. This is CDC data from 2021 and the percent of people who over the age of 65 who fall in each state. And the darker the color, the more people that fall. In particular, this map is showing those people who actually, how many people die directly from a fall. And if we go to one more click, Wisconsin, believe it or not, has the highest age-adjusted death rates related to falls. Every year, 27% of our folks here in Wisconsin over the age of 65 fall. And we have more people that actually die from a fall. And let's go to the next slide. And it's like, well, why is that? The population is older in Wisconsin than the average US average. We have very icy winters, but so does Minnesota, so does Michigan. I know this. Wisconsin, statistically, a little bit more drinking, and that's alcohol, including among the elderly. And what we have found is that officials in Wisconsin, the coroners, the people if they pass away in the hospital, they will usually report falls as a cause of death more than any other states. This is why Wisconsin has been identified as the death state when it comes to falls, but it's usually how you document why the person died as well, but in addition to the other factors. All right, let's get to it. So you can go all the way through. We'll fill up this slide. That would be great. When I give talks to the residents or even faculty, I'll say, there's a couple slides in here that you really, this is the A+ slide. This is where you're going to get a lot of information. If you're going to remember one slide, if it's for the exam or whatever, this is it. Preventing falls at your facility. So the Agency for Healthcare Research and Quality and the Centers for Disease Control and Prevention, the CDC, have put together ways to identify preventing falls at certain facilities, not just skilled nursing facilities, but assisted living and in the hospital. So the first thing you can do actually is assess your staff knowledge. We use this quite a bit. It's the fall knowledge test. It's 13 multiple choice questions, very directly asking, why do you think patients fall? What is your facility doing for patients who fall? What do you think can prevent patients from falling? And it gives you an idea of how much in your facility, how much people know about fall risk and fall prevention. The next is, if you think you have a patient that is at risk for falling, the two scales that we tend to use the most are the Morse Fall Scale and the STEADI Checklist. The Morse Fall Scale was established in 1989, and the STEADI Checklist was 2017. Both of these look at areas in the person's life that are risk for falls. Have they had a previous fall? Their medications. You go over multiple things that can identify their possible risk for fall. And the last one, which is something that we don't want to get to, but a lot of times we have to because they've had a fall, and we call it the huddle. And I know a lot of agencies have gone to this. One of my favorite huddle worksheets is from University of Nebraska Medical Center, and that's listed down there, and it's free. And it's a 2-page huddle worksheet that you work through looking at trying to identify, why did that patient fall? What could we have done to prevent it? And what can we do in the future? So, but we try not to get to this one and work on the other two first. But if you have to, the huddles have made a difference in preventing falls in the future. We use these a lot. Next. So many times I'll go through case reports. So I have 3 patients. The pictures are not the patient. I can't do that, but the stories are the same. And these are patients that I've seen and different reasons why they have fallen. So let's get to the first one. This is John.
Oh,
That's
sorry.
fine. John, we'll leave it right there. John lives in a combination assisted living and skilled nursing facility. I saw him a few years ago, and he was falling quite a bit in his room. He would come out and he would be bruised, and the staff would say, "What happened, John?" He goes, "I don't know. I just fell. I don't know." They're picking up everything in the room. He was just falling. He had little prodrome, which means he didn't even know he was going to fall. He just fell. And then one time they caught him on the camera when he was coming in the front entryway after visiting some friends, and he fell very quickly. They could see him stagger, grab the wall, and he went down. So I know cameras are an issue in Wisconsin. We can use there's a law that there's a lot of cameras that we can use both in the skilled nursing facilities and in assisted living facilities. And not every place has that. And there's different rules on that. We could talk about that later. But John's social history, he's widowed, he's a retired plumber, really no family nearby. There's his medical issues there, glaucoma, so you can see a lot of risk factors for falling, but in particular, the aortic valve replacement, and that will come into play later on when we talk about why he's been falling. He also has sleep apnea, like a lot of your patients do, probably a lot of people online here do, and not everyone can tolerate the CPAP, and later in the day, they become very fatigued. It's very common. Okay, Tony, next. We'll get, I think, to a little more. There's his medications. When we check vital signs, whether I'm visiting someone in their home or in our clinic or in the hospital, everyone gets orthostatic vital signs every time. Every time I see them in the clinic, we always get orthostatic vital signs. It doesn't take that much longer, and it can give you tons of information. That's his gait. It's very slow. He uses a four-wheeled walker. He's got anemia and mild renal insufficiency. Next. This is Louise. We'll talk about what happened to John later in the presentation. Louise lives in the nursing home. I saw her about 2 years ago, and she would get up, and Louise's main complaint was, "I'm dizzy." And I'm sure you've never heard that before. I am dizzy. This is a complaint, and dizzy is like an umbrella term for so many different things that can cause dizziness. But she would just say, "I'm dizzy." And the worst part with her, when she would get up and walk around, she wasn't dizzy right away. It was usually about 10 to 20 feet when she was walking down to the dining hall, the dining area, or walking over to watch, work on crafts or the TV, watch TV. And then she's like, "I'm dizzy." And then she'd feel like she's going to fall. So let's get into her history a little bit here, the next page. Hypertension, Parkinson's, which is a key diagnosis here, osteoarthritis, urge incontinence, constipation, hearing loss, macular degeneration, anxiety, insomnia. All of these are risk factors for falls, all of them. Next page. These are her medications. I won't go through all of these, not just these, but if you click again, she's on more medications. This is what you see a lot in your patients. I'm a huge proponent, advocate of deprescribing on my patients, and we have deprescribed a lot of these for Louise, and I'll show you these later in the talk. And then the next slide, please. So for Louise, like I say, we always get orthostatic vital signs. And for her, she was sitting, she's 137/65, heart rate is 62. We stood her up in about 3 minutes. She actually dropped pretty quickly, 78/57, and a heart rate of 88. The other factor we looked at is weight. We always look back on her weight. She's lost 15 pounds in the last 8 months. Those are her labs, and then we get an EKG, and for a lot of patients, we've had an echocardiogram as well. And those all look pretty good right there. So let's get to the next slide. Tom, this is our last patient. Tom and his wife, Dorothy, moved into the skilled nursing facility. They were first in assisted living, and then the staff, very astute staff, realized that they needed more help. Tom is legally blind. He's been legally blind for probably 35 years. And Dorothy, his wife, has mild to moderate dementia. So they finally moved him into the skilled nursing facility. And Tom continued to fall primarily in the room. And what they did was push their beds together. They made it like their own little bedroom set, but he continued to fall in the room. And it was an astute staff member that saw what happened. And then we made some changes and he stopped falling. So let's get to his history just a little bit here. Glaucoma, hearing loss, knee pain. He's had multiple subdural hematomas from previous falls. And this is our medications. He's on 3, glaucoma eardrops, Tylenol, and Flomax. Not bad. So you have a patient that falls. You are the detective. We have to figure out why. This is what I do every day in clinic. And we ask the question, why? Because many of us who've fallen, or your patients who've fallen, will develop this fear of falling cycle. We see this all the time. Your family member, your patient falls, you fear falling again, you're a little bit less active, then you start getting decreased muscle strength and balance, and now you're even more risk for increase in falling. Fear of falling cycle, very, very common. Next. So 4 steps, what do? We get a detailed history, what happened, multifactorial risk assessment, individualized interventions, and we study your care team. So the first thing, next slide, when a patient comes in to see me, or if I see them in their home, or when I'm working in the hospital, I see them and they've fallen. These are the questions that we go through. Where did you fall? What was the time of day? This is critical to a lot of things. What were you doing? Were you carrying anything? We have a few more slides there. Do you remember falling? How were you feeling before you fell? What were you wearing? That's not it. We have more questions. They are continued. Do you have an assistive device? Were you using that device? And if they say no, you'll see a lot of times they're in a small area like the bathroom or the kitchen if they're at their home and they're not using it because they don't like to use it in there or it's cumbersome. Did they have any new or recent changes in medications? What is their social history? Many of my patients that come in from the community, I need to know this to find out, what's been going on in their home and if that's contributing to their falls. We have another slide there. And the key here also, were there any witnesses? Did anyone see you fall? Next. Any injuries? And then I think we go on to risk factors. So those are just some of the questions I ask, and I don't drill them with a lot of questions. I'm usually examining them, asking them questions, kind of gently prodding maybe what happened here. Sometimes the family member's in with them. If they have mild to moderate dementia, family member, or I'll get notes from the nursing home or whatever, and I can kind of decide how they fall. When I worked in emergency medicine a lot, we would call the nursing facility and say, okay, did anyone see them fall? Please let me know what happened. And a lot of times I know a lot of people are busy, but it will give me an idea about how I can work this patient up and help them from falling again. So let's look at some risk factors. And some of these are very common. You would understand that they are. Lower extremity weakness, history of a stroke, orthostatic hypotension, previous fall, advanced age, and believe it or not, female gender, a little bit more because of strength and conditioning as we age, cognitive impairment, and psychotropic medications. Next. Risk assessment. Are they at high risk? And this is how we determine that. There's a lot of things that we go through. You can just click until we fill up the screen there. That would be great. So whether I see them in clinic, in their home, or in the hospital, we go through all of these. We get orthostatic vital signs. We get a visual acuity. We test their strength, their gait. We watch them walk. We see how they use the assisted device. We look at their feet. We look at their shoes. We make sure cardiovascular-wise nothing new has happened. Many of our patients will come in and now they have a new acute AFib or paroxysmal AFib. Mental status, one of the first signs of mild dementia is a fall. It's very, very common in patients. I don't know why I fell. And then you start asking questions and they may not be able to answer those. So then you think, is there something going on cognitive that I need to look at? We're not finished yet for the multifactorial. So the next page, polypharmacy. Huge. Social history, living arrangements, support, and stressors. Hold on, Tony, just a second. I think one of the best things that happened during COVID, which wasn't many, but one of the best things was I can get my patients on video and I have video visits with them. And then I look behind them and I'm like, Louise, can you kind of pan your living room there for me for a second? And so this is when I'd see some of my patients that I didn't know were hoarding or they had cables or, extension cords on the floor. The chairs that they had were super low. So it was great. I could see their house. And so the home visits, we've cut back on a little bit just because we're seeing more patients in clinic, but it can tell you a lot. So the next slide, please. So checking blood pressure. Many of our patients are told, and you are too, when you check your blood pressure, sit, put your feet on the floor, rest your arm, just relax. But my patients aren't usually symptomatic when they're sitting with their feet on the floor, armrest, they're usually symptomatic when they're standing. So when we check orthostatics in our clinic, we tend to get them up right away. So we sit them first, of course, and then we stand them for a minute, and we have them continuing to stand for 3 to 5 minutes and check it again. And this is when you can really find out if they have orthostatic vital signs or positive orthostatic vital signs. So I see a lot of patients with dysautonomia, which is a wild fluctuation in the nervous system and blood pressure. And we'll have them actually lie down first. You don't have to do that, of course. You can have them sitting and stand. A positive sign, a positive orthostatic sign, is a drop in the systolic greater than 20 or diastolic greater than 10. That is a positive orthostatic vital sign finding. So if you're going to call the provider, you say, "These are my numbers." And there are many studies that show that positive orthostatic vital signs, which is kind of like, okay, it's kind of a little bit of common sense here. When the blood pressure drops, there are more risk for falling. So there are numerous studies. This was published in 2019, looking at over 50,000 individuals that have orthostatic vital signs positive, and they have been falling. So this is why it's so important to check it. Next one, please. So for a lot of the elderly or older patients, what happens is everything slows down. No matter how hard we try, everything slows down. And that includes your blood pressure. And so when you stand up, it may not drop as rapidly as you think. So when you check the orthostatics at 3 minutes, you may like, "Oh, they're fine. This is great." But for Louise, when we first checked hers, they were positive. This is the woman that was walking, but she's continued to drop her blood pressure when she'd walk 20 feet. So many of your patients will have what we call delayed orthostatic hypotension. And this can go on for 3 to 45 minutes. So these are my patients that get up in the morning, they sit on the edge of the bed, they get ready to go, they stand up slowly, then they make their way to the kitchen. These are your patients that may make their way out to the dining room area. And that is when the blood pressure starts to drop. Very common and under-recognized. So I don't know if the patients like their blood pressure checked in the dining room, but this is what we see quite a bit. Common in patients with dysautonomia. Patients who have dysautonomia are those with Parkinson's disease, Lewy body dementia, multiple system atrophy, alcohol-related neuropathies, diabetes that's been there forever will develop dysautonomia, or amyloid. The patients I see the most are those with Parkinson's disease, have significant dysautonomia, and those who have diabetes or have been through chemo and radiation. I see quite a bit of dysautonomia and wild fluctuations in their blood pressure, and we have to take care of that. So what can you do? So we will make a lot of medication changes on when they take them and how they take them, if they're combining them with other medications. Again, a lot of your patients that you have, okay, let's slowly get up from a chair, march your legs before you're getting up, get the engine running, get the blood pressure up a little bit. For some of my patients, I actually, it's interesting, this cohort of patients coming in now, the 50s and 60s and 70s, they grew up with parents that had high blood pressure. So they had no salt in their diet growing up, and now they don't have salt when they're older. So I'm like, you can eat salt. Not many people can tell you that. It's not from cardiology clinic, but you can have salt in your diet to hold on to that fluid so that will increase your blood pressure. Elevating the head of the bed. This makes a big difference in people getting up to urinate all the time. When you're laying flat in bed, the bladder is sensing that your bladder's full. So your body, I got to get up and urinate. I got to get up and urinate. So if you elevate the head of the bed just a little bit, the fluid tends to run down. They don't always cause edema, but you don't have that urge to get up and urinate all the time. And this also helps patients when they have supine or when laying down hypertension, eliminate that or drop that a little bit so they don't wake up with such a high blood pressure. I have seen many patients with postprandial hypotension, and they will actually syncopize. So they have a big lunch, a lot of carbohydrates, they sit in their recliner, they lean back, and they go out. And it's usually the patient's wife, this is statistically, she's like, "No, he just went out. I couldn't wake him up. He was out." And I finally get them to check the blood pressure, and it's like 80/40, 60/30, and it's all postprandial. So what we have a lot of our patients do is graze on food throughout the day and not eat big, huge meals, because that really will drop the blood pressure, particularly if it's carbohydrate. So compression sleeves, stocking shorts, pelvic binders, you've seen it all. If we go to the next slide. How fun is it to get on those compression socks, right? And so for a lot of our patients, we just like get over the counter compression socks. Do not worry about the hospital grade compression socks. It is painful sometimes for the patient, and it's painful the person putting them on and taking them off. If they do not need hospital grade, we just get over the counter compression socks, sleeves, leggings, things like that to really help their blood pressure. Next. I use a lot of medications. I try to take away medications, but the two medications I do use for patients with dysautonomia, the blood pressures are dropping, include fludrocortisone and midodrine. You may see these on some of their medication lists. These complement one another. Fludrocortisone brings in fluid to the body, and midodrine's an alpha agonist. It squeezes it. So fluid, squeezer, blood pressure up. It works like a charm if they don't have heart failure and kidney disease. Most patients, we can tolerate a low dose of both of these. So remember Tom, our patient who had glaucoma. So your patients with visual abnormalities, and to recognize, and many of it, probably say at least 60, 70% patients in a skilled nursing facility will have some vision issues. Macular degeneration is central. It's important to know this too. Central vision loss. Cataracts are global vision loss, and glaucoma is peripheral vision loss. So for Tom with glaucoma, he would bump into walls. He just couldn't see the peripheral area of what was going on. So he would easily bump into walls versus macular degeneration, which is essential. But with all three of these, your patients will have decreased depth perception and reduced ability to see contrast. So if you go to the next slide, many of your patients will also be wearing glasses that are either bifocal, trifocal, or progressive lens. And if they don't need these, we get them out of these glasses and usually use a single vision lens. And that's usually medium distance so they can see the TVs. If they're reading, they can lift their glasses up. But what we find with bifocals and particularly progressive lens is they can't find the spot where they're supposed to be. So you'll have a lot of patients with progressive lens and particularly bifocals or trifocals, which are not usually seen much anymore. They can't find the curb. They can't find the step. They can't see the threshold because they need to get the glasses just right to see it. So this is a cartoon. Having trouble getting used to your new bifocals, you will see that if you ever walk into a grocery store where there's a curb or a restaurant, you'll see people slow down and they're kind of looking to find out, ooh, where do I put my foot next? Single vision lens, if you can get away with it. And if you have patients in your nursing facility that have all these fancier glasses, just see if the family you can use the same frame, just switch out the lens. So next slide, please. So as I said before, falls can be some of the first signs of memory impairment for our patients, and they tend to occur in those patients with non-Alzheimer's disease memory loss. We talk about dementia. This is a whole nother topic I talk about quite a bit. There are many different types of memory issues. So don't assume that your patient with memory issues is Alzheimer's. It may be Lewy body or frontal temporal or Huntington's or vascular dementia from mini strokes all the time. And how they, some days can be good, some days can be bad, depending on what type of dementia they have. Some days they walk just fine, other days they don't. It really depends, and able to read that person and figure out, okay, this is not a good day. We need to help them out a little bit more. One of the easiest things you can do, and staff can do this, you don't have to wait for a physician or a nurse practitioner to come into the facility to run this mini cog. It's free online. It's a great way to test memory. And it's 3 questions, basically. It's a 3-item recall, and it's a clock drawing, and that's about it. And you can say, you know what, I think they have some memory issues, and you can do this at your facility. It's very, very short, very quick. Next slide, please. Check their feet. You wouldn't believe when I take shoes off of patients, what you see. And most of the times in the skilled nursing facility, I know you're helping them bathe and things like that, so you'll see this, but a lot of patients in assisted living or who come in from the community don't have access, or they didn't know that, yeah, that can cause problems when you're walking. If they have a lot of calluses, or they have, I can't use the nails that are fungal infected nails that can be quite painful, or they can't put their shoes on. So look at their feet. Next. Footwear is important. Those on the left, or my left, not good. Those on the right, better choice. These are kind of common sense, but those rubber clogs, many of our nursing staff wear them, physicians, the surgeons wear them. There actually was a couple studies looking at these, and I'm not picking on the company at all, but clogs that are rubber, they don't have a lot of support. People tend to fall in these. So think about wearing those. Next. You may have patients with foot drop, and I've had many patients with foot drop that come in and they need the AFO, the ankle foot orthotic brace, and they didn't know this, and they're getting better and lighter and easier to wear. So think about this in patients with foot drop that you may have. Next, please. Polypharmacy. This is one of the areas that I talk about a lot, give quite a few talks on this, try to de-prescribe patients. The definition of polypharmacy, and most of your patients, a lot of your patients will have this. Some of you listening to this talk have this. Think about it. Taking a medication that lacks an indication, is ineffective, or duplicating treatment provided by another medication. Next one. Polypharmacy is 5 or more medications considered polypharmacy by both our researchers, pharmacists, and clinician. If you, your patients, your family members take 5 or more medications, that is considered polypharmacy. And this includes over-the-counter, this includes CBD, this includes marijuana gummy bears, it includes everything, polypharmacy. Next. The problem with polypharmacy is then we get a drug problem. These are, I put these titles in here from magazine articles: The Dangers of Polypharmacy, Ever-Mounting Piles of Pills, Giving Elderly Too Many Prescriptions, A Quiet Drug Problem Among the Elderly, Polypharmacy. And rarely does anyone take responsibility for all those medications. And to empower someone, the primary care or the person coming in to see that patient, or family members, to say, hey, can you look through their medications? They were just in the hospital for heart failure. They came back on 4 new medications. We need to look at these. Let's look through these and see if any of them interact with the others. Next, please. So factors leading to polypharmacy: about half of older patients have 3 or more chronic conditions and take 50% of all prescription medications. And when I was starting in medicine, I realized that, we would put, I've always enjoyed geriatrics. I started out right away, took time off in medical school to a lot of research in geriatrics. And I realized, some of these patients are on medications that have never been studied in the age of 88. Carvedilol, hydrochlorothiazide, all the medications that patients are put on, but they weren't included in the trials because they were exclusion. They were too old for different reasons. They have many comorbidities. So many of the medications your patients are on, they weren't always studied in that population. So we don't always know the side effects. We get to 2 more things here I put down. The clinical trials do not measure the outcomes of higher priority in adults, such as independent living and quality of life. So if you put them on a diuretic and they're urinating all the time, the timing of that diuretic, do they really need the diuretic? Because that's impacting their quality of life. But if it needs for heart failure, yes. So we go through all of these medications and try to either decrease some, tease out what time we put them during the day. It's so, so important. Medications, I can't tell you how much this will affect someone's life if they're not looked at on a regular basis and identified which ones they really need. So let's take a look at what happens. And some of you may have fallen into this. This is a very, very common scenario that I see. So we're going to just do one at a time, Tony. I think you saw this one on our previous talk. So this is, we call the prescribing cascade. And when I teach residents, I'm like, if you start this medication, think about the side effects and what could happen. So let's go through this one. So the patient comes in with back pain. They're 76 years old. Oh, well, we can treat that. Hold on, Tony. They're treated with naproxen. Well, naproxen is filtered through the kidney. And if you take naproxen or an NSAID for years, for example, this one, 2 years, people can develop renal insufficiency, i.e., their kidneys are kind of like, oh, this is a lot of medication here. Now you're going to develop hypertension. So now your blood pressure is up at the age of 78. Next. Well, I can treat your blood pressure. I'll give you amlodipine, a calcium channel blocker. That will decrease your blood pressure. Oh, but then amlodipine causes lower extremity edema. So you've been on amlodipine for 2 years. Now you have this swelling in your feet. I can treat that too. So I'm going to give you some Lasix. I'm going to give you a diuretic. Let's get rid of some of that water weight there. Then you get up because you're on a water pill. You're getting up to urinate all the time. You don't sleep. So now you have insomnia. Now you're getting a little dizzy. You don't want to drink a lot of water because you don't want to go to the bathroom. So now you have dehydration. Now we look at the other medications you're on. So if you think about it, this is what happens. Someone's complaining of urinary frequency. Well, that must be your bladder spasming. So we'll put you on Ditropan. Oh, you're not sleeping. Well, let's give you some trazodone. You're dizzy. It's got to be vertigo. So I'm going to give you some meclizine. You're dehydrated. Well, now you're constipated. So now I'm going to give you Docusate. And you know what? Let's just put some acetaminophen on there because I think you probably need it too. This is what happens. This is what happens all the time. So we have to peel back, like start peeling these things away from people, but think about how it all started and how we can stop this madness for some of our patients. All right, next slide, please. So medications that are associated with falls, all of these. And I can guarantee you a lot of your patients are on these. Sleep medications, seizure medications, antipsychotics, pain medications, blood pressure antidepressants, anti-anxiolytics, and muscle relaxants. And some of them, patients need these. It's just, do they need them all? And what's cause and effect? And that's what we try to get to in our clinic and what we should all try to do. So we look at, there's different information guidelines that you can look at. Mark Beers is a geriatrician, and he passed away actually from, and this is all, it's not a secret or anything, but diabetes. He had a pretty significant diabetes since he was a child. He passed away in 2019. He developed this commonly used tool looking at medications that can affect the elderly. And it's the AGS, the American Geriatric Society, has picked up this tool, and they updated it again in 2023. It's updated every couple of years, looking at medications that can have potentially inappropriate side effects in the elderly. So just one resource. There are more here I've listed for you. The next slide. One of my favorites is the Stop and Start medication screening tools. This is out of Ireland. There's a website down below. For inappropriate medications, which one to stop? And like, well, if I'm going to stop this one, which one can I start? So this is another great tool that you can use. Next one, please. MedStopper is another one of my favorites, an online tool. You can easily go in. It's all free. You get in there, put the medications in, tells you which ones to stop, which ones you may want to consider discontinuing or lowering the dose. It's a great tool to use if you have patients that come back on new medications, like, well, wait, what is that one? Let's try to look at this. And we use this one in our clinic. Next one, please. So this is an interesting study. And if you think about it, again, for those listening in today, and then for your patients, I just love this title. More than 90% of patients are willing to stop a medication if the doctor says it's possible. This is strong. If I say to a patient, you can stop that one. They're like, really? And they're usually pretty excited. Or sometimes they'll say, well, did you ask Dr. So-and-so who prescribed it? And I'm like, I will, and I think we can stop it. And I do that. I always check with the prescribing provider. But most patients, if you tell them we can stop it, they will stop it. Next one, please. So 2 more tools, the deprescribing. This one is out of Canada. If you have patients on antipsychotics, benzodiazepines, this is a great tool, how to deprescribe, get patients off these medications. And then there's a good palliative geriatric practice algorithm that you can go to as well. So these are just guidelines that you can look at your leisure. Next, please. So let's get back to John, Louise, and Tom. So we get to John. So remember, John was passing out, actually he was falling, sorry, I just gave you the hint there. He was falling in his room. He's assisted living. And then they caught him on camera in the hallway coming in, or the entryway. John was actually syncopizing. He was going out. He was having loss of consciousness. Let's get to the next slide, please. This is a comment that's in one of our papers. I never realized I was losing consciousness. Each time I found myself on the ground, I thought I had just tripped. This is so common. Patients are like, nope, I just fell, didn't lose consciousness. I was awake. But usually when someone comes in with loss of consciousness, go to the next slide, please. I work with patients who syncopize. And so syncope in the older patient is usually underrecognized, particularly in acute care settings, and it's very atypical. Many of your older patients who are actually passing out have little warning, and they usually don't remember that they passed out, and they usually unwitnessed. So for John, he was in his room all the time, his assisted living room, and would come out and he'd fall and he'd gotten up, and then he's out, out and about until someone actually fall. And we saw it on the video, and they actually brought it in. We could see the video, and we kind of knew probably what was going on. So we get to the next slide, please. So he was having syncope, he was loss of consciousness. And when someone comes in with loss of consciousness, it's not just, oh gosh, you were dehydrated. No, there are many different reasons. And so these are the categories that we look at when someone loses consciousness and which one they belong in. This is part of my job. And what I'd love to do is figure out why people are passing out. The most common is reflex mediated. I can guarantee you people listening in today, probably about a quarter of you have had reflex mediated syncope. Blood draws, hot weather, things like that. Dysautonomia, I see a lot of patients, Parkinson's, like I mentioned, cardiac arrhythmia, and structural heart disease. So these are the categories that we look at when someone syncopizes. Next one, please. So for John, if we went back, John, remember I said he had the aortic valve replacement. Any of your patients with any cardiac work, particular on their valves, aortic valve in particular, mitral valve not as much, but the aortic valve, that is right through the conduction system, through the wiring of the heart. And many of your patients, and I think who is the actor? He used to be governor.
Arnold Schwarzenegger.
Arnold Schwarzenegger had his aortic valve replaced years ago. And then he had to replace again. Well, this week he had a pacemaker put in. This is exactly the same story. The electricity doesn't get through, the scar tissue starts to develop, and then they have these pauses. And this is what was happening to John. So John, we finally we got a monitor on him, found out he was going into 3rd-degree heart block, long pauses, nothing was going on, and he got a pacemaker. John is no longer falling. So something to think about your patients with cardiac issues. Next slide, please. So Louise, remember Louise, she would get up, she had Parkinson's disease, she would get up and we found out her blood pressure was dropping. So let's go to the next slide. So she has dysautonomia. So we started deprescribing. She's lost weight, she's dropping her blood pressure. So if you click through these, Tony, we'll get through. I stopped the lisinopril, stopped the aspirin. There's no need. A lot of your patients on aspirin, they don't need to be on them. Oxybutynin, multivitamin, she's eating well. She's on vitamin D. Next slide. Lorazepam, we were able to wean her off that. She's drinking more. She stopped being constipated, died her off that. But again, I took away about 6, but I had to put her on 2 to bring this blood pressure up. Fludrocortisone and midodrine. She is doing great, no longer falling. She feels good. She's more active, able to participate in things. Happy soul. And this is all due to the Parkinson's disease and the dysautonomia that occurs. Next one, please. Tom. So Tom and his wife move into the skilled nursing facilities, kept falling in his room, and it was an astute staff member that was walking by that said, his wife is trying to help him every time. Tom doesn't know, he can't see anything. She has dementia. And so what they decided to do, let's get to the next slide, please. Separate them, put them into separate rooms. Tom stopped falling. You got new hearing aids, physical therapy, walker adjustment, and no other falls. It was all due to their social history together, 60 years helping each other out. And the staff said, we're going to separate them. And it worked like a charm. So I love that one. Next one, please. So type of exercise that helps, gait and balance strength training. Even if they come back after hip replacement, get them into PT, get them strengthened. Movement, Tai Chi, aerobic activities. We all know this. It's important for us to do. Let's get to the next one, please. Next one, please. Canes. A lot of your patients use canes. Many, I tell you, there's not one resident that I've taught or a medical student that I've taught that have come through that know anything about canes or anything about walkers. And I'm the one to teach them because someone taught me during my geriatric fellowship, and she was a physical therapist. So 10% of those over the age of 65 use canes. carry the cane opposite to the weak leg. You size the handles to the middle of the wrist. We'll go through that in just a second. You look forward, not down, pivot on the stronger leg. And the key is with steps, the good leg goes up, the bad leg comes down. Next one, please. These are different walkers, two-wheeled with glides. My favorite, the rollator walker. If they can handle the rollator, it's 17 pounds, easy to use. Bigger the wheels, the better the walker. And then there's the U-step walker that we use for a lot of our patients with Parkinson's disease. It has a very heavy front area of the walker, and because most patients with Parkinson's disease tend to fall back. So a lot of weight in the front. This usually helps them quite a bit. So when you have patients come in, even if they're coming from the hospital, many times they do things, you can be in a hurry and there's no blame, but they'll come in. Probably about half the patients that come into my clinic, I'm adjusting their walker. The same for the walker as the cane. They have them stand straight up, walk towards the walker inside of that, and the handle to the walker should come to the middle of the wrist. Many of our patients will have their cousin's walker, their spouses who died, their walker. They buy it at the senior center or a garage sale. Walkers are not cheap, so they get them. So just adjust them appropriately. Next, please. Home improvements. We'll get through this. Time for questions. I think these are just pictures.
Sorry, I'm going backwards here.
That's okay. I'm going to go back one.
Yep,
This
I'm
is
trying
key
here.
for patients that particularly living in nursing homes. If we can't go back, that's okay. That's okay. Okay. So the thing about the carpeting, so patients, the ejector chair, I call this. And my father-in-law actually has this and it works for him. And my aunt, who's 98, has one of these and she loves it. She can handle it. Some patients can't handle it, so be careful with those. My father had a recliner that we could not get him out of, no matter how hard we tried. So it was an occupational therapist that said, get some risers and stiffer padding. And we made his recliner higher off the ground so he didn't have to rock himself to get out of the recliner, and then he would fall, of course. So different things that you can do to make furnishings safer. We'll go on to the next, please. Floor patterns are important. Remember the contrast. This one's too shiny. This one has a lot of pattern that may be confusing. And the one on the right upper corner, that's a nice way to find out where they're walking down the hallway. That's from a clinic that we have here. Next, please. Rugs, we all know loose rugs are not good. Take them up if you can. Next, please. Very common. Like I said, my father-in-law lives in assisted living. We're always going in and picking up the clutter and moving things, and it makes a big, big difference in the wires. Go back, please, or forward, please. Night lights are important. Too much glare is worse. Poor illumination. Next one, please. And one of my favorites is the contrast. My father had glaucoma as well. It was occupational therapist that said, put some yellow tape on the steps. I put some more railings on. He stopped falling on there because he could see where he was going. So, so important to have contrast on those steps. Next, please. Grab bars, my favorite. So I have a patient with multiple system atrophy, loves to cook, does not want to use her walker in the kitchen. So we decided to put grab bars all around her kitchen cabinets. And now she can hold on to those and she can still cook, which makes her happy. She can turn and grab her walker. So important. Another grab bar that's important is in front of the toilet so that when they get up, they can push off the toilet, but to grab onto something so they can pull up their pants. Where you put these grab bars is really, really important. All right, next, please. Bed aids, if they can have those, some facilities don't allow those, but they've helped some of my patients, particularly living at home or a senior apartment. Next, please. And so at the end here, STEADY, Stopping Elderly Accidents, Deaths, and Injuries. The CDC has put together a wonderful, wonderful free tool site for you to use to steady your team so that you stop having your patients that fall. And we use this quite a bit. I send patients home with things that they can do at their house. And this is something that you definitely want to tag yourself into for the study from the CDC. Next one, please. Bottom line, this is the last slide, so we have time for questions. Identify patients at risk. If they're wearing that wristband, if we go back just one,
Yeah.
please. If they're wearing that wristband, ask yourself why. Why are they a risk for falling? Multifactorial assessment. Remember all those things that we went through, and that doesn't take too long. For me, it takes maybe 20, 30 minutes to get through all of that. And we can do it in clinic. And then individualize your intervention. If you go down here, Tony, to the bottom, that is a great article, Fall Prevention in Hospitals and Nursing Homes, Clinical Practice Guidelines. This is just published in 2022. So another great resource for people to look at. And the bottom line, honestly, it's all about balance. It really is. If someone has balance, good balance, you usually don't fall. And so this is one of our Tai Chi classes, and you look at the different age groups there, it's just lovely, but it just works. It works. Tai Chi is lovely. So that's a lot of information. Thank you. And I'm ready for some questions.
All right, well, awesome. Gosh, I sure got a lot of good ideas during the presentation, and I'm sure the rest of the participants did as well. So I didn't see any questions come into chat, but again, now would be the time if you have any questions that you'd like to ask Dr. Walsh or any comments, please feel free to do that now. If you'd prefer to ask a live question, you can click on the bottom of your screen and unmute yourself and ask it live verbally. If you're on the telephone and you want to unmute yourself, it's *6. So while we're waiting we're getting a lot of comments here about how great this was, an excellent presentation. I was just curious while we're waiting for any questions to come in, if the folks on the line here typically are incorporating orthostatic blood pressures into their either like a baseline assessment for residents or if that's part of your fall after someone falls, if that's kind of typically part of an assessment that you're doing. So if anybody would like to share any thoughts about that, it would be greatly appreciated. Okay, so Deanna says that it's part of their post-fall intervention. Was anybody surprised, besides me, kind of surprised by the length of time that we might want people to stand? I didn't know that. And I think of the people that we struggled with, who kept falling. And I'm just thinking, gosh, I wonder if we had utilized that, and kind of did some more serial blood pressures with them standing longer and longer, if we wouldn't have been able to, have figured something out there. Any further comments on that, Dr. Walsh?
No, it is very common. And those are the patients that say I'm dizzy or I'm lightheaded, but the dizziness, and we try to tease that out between spinning dizzy and lightheaded. And sometimes you're just like, okay, we're just going to assume that you're lightheaded, especially if you're standing. They have to be safe when they're checking it. So I'll have patients living by themselves.
Yeah.
I'm like, make sure you have a countertop, make sure there's a chair behind you, and we can check it, or their daughter-in-law comes over or neighbor comes over to help them check it.
Yeah. Go ahead.
And if you do have it, and when I gave this talk before and you were at the presentation, Tony, one of the staff members said, how do we tell our doctors or the providers, like, look, we should probably change this medication. And sometimes you'll call and everyone is busy. Everyone, the volume of patients we see is just keeps getting higher and higher. So empower yourself to say, hey, can we stop this medication? When I work palliative care, the best thing they ever did at 2:00 in the morning was say, I need to increase our morphine from 10 to 15. Can we do that? Yep, let's do it. Or just think about what medications. Just don't say, they're dizzy. And but then if you have orthostatics, you have some objective data to say, hey, they're orthostatic. If they say drink more water, like that's one, but let's look at their medications.
Right.
So
yeah. I see, let's see, Vanessa had a question. Most nursing home residents trigger as high risk for falls. Is there a risk assessment that can narrow this? And Vanessa, I'm thinking by the question you're asking, narrow this, are you asking about, are there tools that kind of can help narrow it down between what the cause might be. Is that what you're asking? Yes, she says
Yes.
yes.
So the Morse, it's about the fourth slide I had there, the Morse fall scale and the CDC, they go through and it's like 7 different domains. And that helps you tease out like, okay, this is probably contributing to falls, this is contributing to falls, and this. And so, because it's a lot, so many factors can affect falls, but those 2 scales, those 2 instruments we use a lot, both in the outpatient, inpatient. So, and those are free online, everything's free.
And I see that also Ashley posted that therapy can be really helpful in helping to do some of the assessments that they do, like a Tinetti, for example, some of those tests to help sort of either eliminate something or contribute something.
Oh, absolutely. It is absolutely teamwork. And I will get messages when I'm at work from physical therapists working with my patients and say, hey, I found this. Did you know it, or can we help? And it's like, no, I did not know that. Thank you. Because no, it's everyone. It's the night staff watching plays, everything that's going on. People change all the time, and it's really teamwork. So.
And then I know too, it's so important to gather as much information as we can about each individual resident, because you had mentioned at the end, what interventions might work or be appropriate for me are not the same interventions that would be appropriate or work for Kim.
So, right. So some of them are common.
Yes.
Right. Common risk factors, especially like vision, neuropathy, lower extremity neuropathy, back pain, very, very common, but trying to figure out what are the top 3 that are contributing to this patient's falls is key. So that's probably how I would look at it. How they get up out of the chair. I tell you, the vision is so key. And if they're wearing these glasses, it just makes their mind like, where am I seeing? So that's one area. And then the blood pressure and the medications. And those are probably, the medications are probably one of the top factors I see. And I'm peeling away on that a lot. And then underdiagnosed dementia. But is the dementia from some of the medications, the antipsychotics, something to chill them out? They get upset. The Tom and Dorothy in the story were my parents. And they went into the nursing facility. And when they said we're going to separate them, I'm like, oh my God, you're kidding. Oh my God. But it worked like a charm. But my mother would fall, and she broke her hip, actually. But she would get up in the middle of the night. But it was the staff member that said, you know what, this irritates her. She was a secretary at one time in her life. So they would have her like folding envelopes at 2 a.m. and stuffing them just to keep her, and so it's recognizing each individual and how you can help them decrease the stress, decrease the anxiety, and not get so agitated they're getting up and falling. So.
Let's see. I know Kim has posted our event evaluation a couple of times. We'd be really appreciative if you could take just a minute or 2 and complete that. We use those all the time for our own internal process improvement. And not take your suggestions about further events or activities that you may find helpful to you. So we'd really appreciate that. And let's see here. I think there's another comment, Kim.
Yes.
So from Heather.
Yes. Oh, go ahead. Go ahead, Dr. Walsh.
Yep, I see that. And that's very common. So when someone comes in, and I'll see these folks and like, okay, what time of day? What were they doing? Did they get agitated by somebody else? Were they not using all these factors that come into play? And usually we find a pattern. The key is finding the pattern on when it's happening, what's happening. Did they just eat? Are they having bowel movement? All these things that can go into with someone with dementia. And believe me, my family members, so I've seen that. It's not just medications for these folks either. And sometimes they'll get mad at you when you say, Louise, let's use your walker, and like, smack you around. Like, I'm not going to use my walker. Like, let me do my own thing. And then you just have them sit down. So finding a pattern is key. And sometimes when you say they get agitated, the last thing you want to go to is something to calm down their agitation, figure out why they're agitated. And if it's sitting next to the guy, that's what my mother was. She's like, listen, buddy, I don't want to sit next to you. And so the staff was great. They would like, okay, that guy irritates her. We're not going to ever sit next to him, because she'd get irritated, stand up, walk away, fall, and all this kind of stuff. So, if it's a certain time, so Heather, I would think of the certain time of day and what they were doing and where. Was it in the cafeteria? Was it in their room? Was it in the bathroom? What was going on? I hope that helps a little bit. That's how I would look at it.
Well, we are a little over time here at 1:01 p.m. So again, Dr. Walsh, I want to thank you for an excellent presentation. This has been recorded, so it will be posted in a couple weeks, and we'll make sure to share that with folks. And again, just thank you so much for everybody today for joining us. We're really, really appreciative of it. So
it was my pleasure. Thank you for all that you do, and bless you all. Goodness.
On behalf of Superior Health, we also say the same thing to all of the nursing homes that we work with. So, all right,
we're here to help.
Take care. Have a great afternoon.
Thank you. You as well. Thanks, everyone. Okay.